Mic test 4-2. Mic test 4-2.
One, two, three, three, two, one. Test, test.
Some. Forgive me for eating and speaking, but we're going to go ahead and get this underway because we have 2 board members that need to leave by 2:30. So hopefully we can expedite the agenda items today. But we are going to call to order the Quality and Patient Safety Committee meeting. I don't believe there's any citizens wishing to address the committee today. No? Okay. And then, therefore, I'm going to continue on, and if I could get a motion to approve the minutes from the Quality and Patient Safety Committee meeting from November of 2024.
Move approval.
Second.
I have a motion and a second. And I would like to then move on to our patient voice, and it's Dr. Carla Pitti and Dr. Badamosi.
Good afternoon, everybody. We are doing everything to be as fast as possible today. We have a robust but tight agenda. As usual, we like to start these meetings by bringing the patient into our midst. This might be a video that you have seen before, but I think this was still a good representation of what happens at JPS, so we wanted to play this as our
being led
patient
along
voices.
by those that you begin to trust, that you know that they want to try to take care of you, they want to try to help you. And since you don't know what to do, you find that comfort in their guidance. The cancer itself, I probably had it for years prior to 2019 when I finally got the diagnosis. I think I had missed a lot of key points, a lot of key signs to the cancer because I made up excuses for it, or had that mentality of, well, I don't have time to go to the doctor because I've got to work, I've got to pay my bills, I got to do this. So that's when they had diagnosed me with the stage 4 non-small cell cancer that had went metastatic. Oh, I didn't want to know the time frame, but I knew it was quick. My little brother got in touch with JPS and started the treatment. At that point, I just knew all I could do was just take it one day at a time, and that's how we had started the phrase sunshine and smiles.
It's a lot of days where it's so hard to put that smile on your face or be positive, but I know I've got to do it for her because it's going to lift her spirits.
The idea is not to get too content and give up, because you never know, like in my case, when something might come about, even on a chance, that could change the outcome. And that's, I think, what happened when Dr. Nara came out and said, well, you know, hey, we can try this immunotherapy.
She always had a step for us to take. And then when there wasn't one, she found one.
What immunotherapy does is it tries to enlist the patient's immune system and fight against cancer. Within a few months, we started noticing improvement in her breathing, in her scans, and I think I gave that immunotherapy for about a year and a half or so. Yeah, so, and by then the CT scans were completely clear.
That's what changed the course of her cancer. Dr. Nara, her knowledge, everything she did is the reason why she's here.
Her story inspires me to keep doing what I do. And usually nowadays when I see her for a 6-month visit, most of our chat is just social about life in general and you know, how she wants to contribute to the success for others and how she wants to give back.
Even though I was at my worst, I still had time to breathe. I had time to walk out in my backyard. I had time to plant flowers. I had time to do these things that I never had time for. You know, and I got to spend more time with my family, you know, in that sense. So it gave a lot to me. I don't think my struggle was near as long as what a lot of people had endured. And so I feel very grateful for what everybody has done for me.
I've seen this video thrice, and every time I think about that story, 5 years ago, if somebody had come to us and said, I have a stage 4 non-small cell lung cancer, to have that kind of remission, we didn't have the drugs, the immunotherapy, but I think still the human connection as to what makes, you know, caring is so unique at JPS. So anyway, I'll hand over to Dr. Badamosi to talk about the Joint Commission updates.
Thank you very much, Dr. Kalapodi. Good afternoon, everyone. I'll try and present expeditiously, so as based on what the chairman just mentioned. Now, for Joint Commission, this is really our closeout for Joint Commission. We did send to the Joint Commission evidence of standard compliance for the few action items that we had. We submitted on the 13th and got a response back a week later that these were all accepted without any changes. All of our submission contained for each of the action items, corrective actions, sustainment plan, as well as an audit plan to ensure ongoing compliance. Based off of these, we have received TJC accreditation that is valid usually for up to 36 months and TJC recommended continued Medicare certification, which is what is expected, the expected outcome of this.
All of the corrective actions done, or is it just, have they already been completed?
Yes,
They're
ma'am.
completed.
It's been completed.
And approved. Okay.
Yes, completed and submitted and accepted.
Excellent. You want to move on to the quality priorities, Dr. Badamosi?
Yes. So we're bringing back the quality priorities to you. We had presented these at our last meeting to kind of like set a tone for 2025. And the two priorities we'd like to keep you updated on is patient experience and the Africa program. As a background, patient experience, our data basically consists of regulatory data as well as non-regulatory data. The regulatory data are mandatory and they are included in programs such as HCAPS and OS CAPS. These are part of the hospital value-based payment system and programs to really ensure that we are taking into consideration patient experience as well as the outpatient quality reporting system. Patient experience also features prominently in the CMS star rating as well as Leapfrog. From all of these, it's clear that patient experience carries a significant reputational and financial impact to the organization. However, these data are collected with a lag time of about 42 days to give patient time to response. And typically, the national average for the response rate is about 21%. Now, there is a second part of this, the non-regulatory data. We get to determine with our vendor what these questions are, the timing and the turnaround time on those questions. And we can actually use those to drive change. But stepping away from the data, the goal of our effort on patient experience is actually designed to create an organizational reorientation and go beyond the data to foster culture change. I think Dr. Duncan said it well, actually, while speaking to us a few days ago, that we will present all of this data. The data has their role, but the more important thing is when we start hearing it from our patient, we will actually know that we're doing what we said we're going to do. So we will use the data for what they are meant for, but our goal is actually to change the culture at JPS and to reorient the organization towards prioritizing not just healthcare quality, but also patient experiential quality of the care they are providing, and giving patient a voice regarding how we define quality, not just from our perspective, but also from our patient perspective, what their view is on quality care. To that end, this is where we currently are and for patient experience, and I will also highlight that this is a metric that is part of the AIP goal, and we have a weighted average to the far right of the slide that takes into consideration the inpatient, outpatient surgery clinics, emergency department, behavioral health inpatient, as well as behavioral health outpatient. And our weighted average is currently 76.1. Now, this is the metric statement that I just showed you, and our opportunity here is actually to foster a culture change and to go beyond the numbers and to really ensure that we are taking proactive steps like leadership and executive rounding on patients while they are here, and really initiating service recovery on real-time patient issues as they are detected or once they come into light. The other thing is to create a patient experience steering committee at the leadership level to ensure that all of this information is actually rising to the top, and all of the action item recovery plans are also being executed and have executive sponsors, and to provide real-time feedback, because sometimes with patient experience data, there is a lag, as I indicated earlier. Giving a physician or a nurse a feedback 6 weeks after they saw a patient, they may not remember. But if we are rounding on the patient and getting direct information and feedback, we can provide those feedback to the frontline staff real time. And our supplemental questions may also help with this. And we are in short order anticipating that the Chief Experience Officer will join us soon. And I think I don't know the exact start date, but there's been the hiring has been concluded. Next, I'll be speaking about Africa. Just to kind of remind you, Africa is a program that is targeted at Medicaid patients. This is a quality measure to ensure that Medicaid patients specifically are getting some quality metrics attached to their care. The way we have implemented it here at JPS is to ensure that we feel and agree that these measures are actually good for everybody. So all of our action plan is targeted at all patients, but we report these to the program as indicated, the STAR and the STAR Plus program. We report this specific patient population to the state as required, but all of the action item covers every patient. And it consists of 6 measures, 3 benchmark and 3 improvement over self, cesarean section rate, readmission, post-op sepsis, as well as food insecurity, flu immunization, and safe opioids. And this is our current scorecard. Using our OB team, I have to give kudos to them. I've done tremendous amount of work. And you will notice our baseline of NTSV, which means term, vertex, and singleton and nulliparous pregnancy, had a baseline cesarean section rate of 28.6. With all of the hard work that's been done by our team, we've brought it down now to 24.8. But if I may actually draw your attention to the last 3 months number, we are in 18, 16, and 20%. These are really, really remarkable numbers, and really does speak to the effort and the amount of work and attention that's been put in by our women and infant team here at JPS.
So we have Dr. Carson Henderson here. Welcome. I mean, when this was brought to the internal team, I mean, we were really blown away with just the improvement. Do you want to share any highlights of what the team has worked on to start to bring those?
It's really been a remarkable collaborative effort between nursing and the providers, the physicians that are working on the labor and delivery deck. Pam Gessling, our executive director of nursing, did tremendous work with the nurses as far as labor management, Pitocin management, really making sure that everyone was clear on their education on what it took to deliver a baby. And same thing with the physicians. Our step 1 was just letting everyone know where we were and why it was important. And after that, just really working collaboratively with everyone to make sure that we were giving patients every possible opportunity for a normal vaginal delivery and not rushing people back to the OR. So really proud of our team. Tremendous work across the board.
Thank you, Dr. Carson Anderson. Yeah, a lot of work went into that. The second metric is the post-op sepsis rate, and we are still at 0. We've not seen one, and we intend to keep it that way. The most difficult of the metrics is the planned all-cause readmission. We're at 19.57 because, again, the way the readmission is defined under this program is both inpatient and observation. So that is a big metric. As a point of reference, the national, just inpatient alone, is about 14.6% readmission nationally. So adding that to observation, most places report around 25 to 30% readmission. The state sets, the HHSC target is 12.6. They've actually gone further down to 12.4. But we're still working on our strategy. We have a daily review meeting on readmission every day, and we're reanalyzing all of our data over the past 1 or 2 years to see if there are additional lessons that we can start applying much more broadly. We're still screening for the SDOH, and food insecurity is one of the SDOH that's been highlighted in this program, and we continue to do very well. Our number has a very positive trend, and we anticipate continued improvement with food insecurity. Same with flu shot, and same with the safe use of opioids. For all of these three metrics, we actually do have all of our processes and improvement plans hardwired. So it's really automatic. A patient shows up, have an interaction with the system. There is a process in place to ensure that they actually get screened, and follow-up plan is provided, as well as getting the flu shot and safe use of opioids. There is a pop-up to ensure that we do not do that.
This is amazing. It looks like our major area of focus will be the all-cause readmission rates. And if you could just briefly just summarize what the kind of the current status of that is and what we're doing to work on it.
So our current readmission effort is actually focused on group of patients, the highest risk, our MVP program, that have the highest rate of readmission. We do have specific patient-level review for all of this patient. What can we do? What are the social determinants that is driving this readmission? And every time they come in, they meet with a case manager that really goes over, what didn't we do the last time? What part of connection did we not get you the outpatient appointment, or why were you unable to make your follow-up appointment? Because our same data actually show that if they're able to make their follow-up appointment, their readmission rate is lower. So we identify risk factors and modify during that index admission. Then we look at what other structural determinant of health they have, like housing, try to connect them with resources, follow-up calls post-discharge. The other bucket of this is one of the most common driver of readmission in terms of diagnosis is heart failure. We do have a heart failure program that actually evaluate patients admitted with heart failure in the hospital, look at the action plan, discuss with them, provide education prior to discharge, and ensure adequate follow-up when they are discharged. Now, these two programs, both based on the patient characteristics in terms of multi-visit and multiple readmission, as well as diagnosis-based, we have a lot of data and experience now since we've been running this data for about over a year now. Now analyzing it, what are the lessons learned from this program, and now seeing which other population can we include in this and expand the program further. But again, this metric is really one of those very, very tight metrics that we have to continue to work on, and still developing strategies around connecting the dots organization-wide to ensure that before discharge they understand their diagnosis, we address SDOH as best as we can, we connect them to outpatient follow-up, and ensure that they do come to the clinic rather than to the emergency room for admission. And if they do, there is also a team in place to figure out what did we miss or what went wrong, and for that specific patient, what intervention can we target at remediating that.
Dr. Holland, if I may add, when we look at the proportion of patients who are MVPs who readmit, that number has steadily gone down. The total number of readmissions we have for the entire hospital is holding steady. We are continuously between 11 and 11.2, and that has not changed. I think the population that we are looking here is a small segment of a population that has some of the highest challenges in accessing healthcare and following up with healthcare. And the other thing that I want the committee to be aware of is these numbers are not risk adjusted. So critical access hospitals with 10 beds that has an average daily census of 1 has the same readmission number than a 600-bed hospital that has an average admission of 120 patients a day. So it's not risk adjusted, it just takes the Medicare population. So I think what we are trying to do last year, I did meet with a lot of regional CMOs and asked this question: how can we advocate to get some risk stratification with this to make sure that it's actually trying to compare the right hospital with the right number. I think we'll continue that work, but I just want to give you that context. The work that's happening at JPS to improve readmissions is just phenomenal. Each patient who gets readmitted has a team that meets almost daily and trying to ask a different question to say, how can we do better to keep you out of the hospital? But I think this is a number that we'll continue to work on, but it's just a very tight metric that that's in front of us.
Ask a question.
Yeah.
So the whole Africa scorecard is using only Medicaid patients, is that true?
Correct.
For all of these metrics?
Yes.
Star Plus.
And so you're saying our readmission rate for the entire hospital population is more of 11%?
Yes.
Okay, thank you.
Yeah. You get some credit.
Some credit, yeah.
Anybody have any more questions on that topic? All right, let's move on to the quality dashboard.
So I would like next to present the quality dashboard to you. And we have reimagined this dashboard and identified 34 key metrics, and we've organized it into 7 sections. The aim of this dashboard is actually to showcase the extensive data collection that drives a whole lot of quality across the organization. We do not bring all of it to you routinely, but we actually do monitor a whole lot of these and more. But these are the ones we've chosen to represent us on the quality and patient safety dashboard. Each of the metrics actually have an action plan and a process around influencing that number. It's just not about the number, but we are seeking to actually create a process around improving it on an ongoing basis. The structure of the dashboard, it's actually about 15 pages. There is the first page that gives a global high-level overview of all of these measures, followed by a section deep dive, and I'm going to show examples of these that provide additional insights into these sections. And the last 4 pages contains definition of each of the metrics that we discussed here, what the numerator is, what the denominator is, so that everybody will understand exactly what we have been measured. As Dr. Kalapudi highlighted, readmission in the context of Africa is different from readmission in the context of regular hospital readmission. And the dashboard also informs us, it helps us develop an affirmative metrics. And what I mean by that is, if I present CARDI to you, the follow-up, the affirmative metrics to CARDI, that is catheter associated urinary tract infection, what does that look like to a physician? It means, how do you review the need for a Foley catheter every day? And do you discontinue Foley catheter in a timely fashion? That is the metric that that physician will be held accountable to. For a nurse, CARDI looks like, okay, did we follow the standard bundle, in the insertion bundle for a Foley catheter? So all of those metrics are cascaded down, and what you are seeing is the high level, what the direction is. But each and every one of those do have specific action plan. And where there is none, we actually build in, and we're in the process of developing that. And so this is the first page, the global page, that shows all of the 34 specific metrics divided into 7 sections. The first section is patient experience, given that that's the overall organizational priority. We do have metrics for access, and then CMS mortality, and hospital outcomes, and patient safety, as well as infection prevention and patient safety indicators. Now, even though we adapted some of this definition from CMS, we are not limiting the patient to just CMS patient. It's for every patient. We just took definition from them. And this is the example of a deep dive, using patient experience as an example. It deep dives into the monthly achievement for patient experience for each of the KPIs under patient experience, so that you can actually see what our exact trend is, and hopefully by the end of the fiscal year, you'll have 12 months of data to actually see the trend. And at any time, questions can come or be asked regarding the directionality of the data itself, which provides additional insight and information regarding the data. And the next example is the definitions. The definition of each of these metrics, each specific KPI as a definition with a denominator and numerator attached to it. And this is done for each and every single metric that's on the main page.
So, Madam Chair, I like saying that, Madam Chair. I know in the past the board has, and Dorothy, I'd like to have your weigh in on it too, but I know the board has tasked us with coming back with more of a dashboard that represents the entire district. And so I would like to commend Dr. Batamosi for reaching out to each of those areas across the district and bringing that forward to the board as a dashboard. So,
Yeah, this is amazing. This is incredible. And I love that it crosses kind of everything that we do. It's both inpatient, but it's outpatient as well. It's not just looking at one aspect of what we do here. And you could see how this is expandable. You can continue to increase this as we, start. Because, I'm not as familiar with Africa, but I'm familiar with like the CMS, the STARS metrics, and it's not just maybe the 2 or 3 things that we focus on, but it's like 99 different things that we have to be doing well to be successful in their eyes. And so it's a huge undertaking to be considered high quality in the eyes of the payers. So, yeah, you have to have a system to track it all.
Yeah. I think for a future where we are going to be investing in the technology to try to actually benchmark to national standards, what is missing in this dashboard is actually benchmark to what should happen at JPS. I think now that we have a template that's global and robust and the metrics, when Vizient finally gets implemented, we'll have the data to be able to say, how does JPS perform compared to other safety net systems in the country on metrics, and what is that? So I think we can then set targets across the nation. Right now what we're doing is we are benchmarking ourselves to either the CMS population, that's only 9% of our inpatients, and it's not reflective of the entire population that comes to us, or we are benchmarking to improvement over self, which is also not truly what's happening. So it kind of sets the framework for a future that is being built on the technology side. So.
Anybody have any questions?
Yeah, I had just a question on some of the definitions. For the sources, like on slide 20, there's 3 sources, iOS, CMS, and NHSN. Can you define those 3 sources?
Adams, you want to take that?
Oh, yes, please. CMS is Medicare, based on their iOS is improvement over self. NHSN is National Healthcare Safety Network, which is an arm of the CDC that looks especially at hospital or healthcare-associated infection.
Why are the patient experience metrics improvement over self metrics? Maybe I don't understand that term.
Yes, so we are looking at what was our achievement for FY24. So we want to get better. There is no national standard. You have to get as high as you can with patient experience. The higher is always better. But since we just have to constantly remind ourselves, this is where we're in FY24, and that's the number to beat. And we still want to beat it and even go beyond that. And as you very well know, it's also an AIP goal that has different threshold, target, and stretch. So we're also very mindful of that.
So self is not the patient, self is JPS.
That's the JPS.
Correct, in this
Improving-
context. Oh, yes, yes, sir.
Over our previous scores. I see.
It should be improvement over past performance.
Thank you.
Any other questions? All right. Then we will continue on to the quality presentations.
So in October and November, we did meet at the JPS Network Quality Council. We also did meet in December, but we are still refining some of the data and information, and we'll be bringing those to you at the next meeting. The two committees that met in October was Environment of Care and Rehabilitation Service, and in November, we had Care Management and Infection Prevention and Control Committee. They did share their report with us, and I will be presenting those in a summary fashion. For Environment of Care Committee, they are really a multidisciplinary committee that looks at the facility and our equipment in terms of maintenance and operation, and also they participate in developing emergency preparedness plan. And even importantly, they ensure that as an organization, we are compliant with regulatory standards set by the CMS and Joint Commission. There's a lot of committees that report into this committee as well, because they touch everywhere across the organization. Some of the metrics that they presented include reduction in needle sticks injury per 100 FTE. And some of the opportunities are staff education and compliance with safety design, because in all of their investigation, anytime there's a needle stick injury across the organization, it's usually lack of compliance with safety design. And we are also looking at evaluating the reporting structure of these specific metrics, and in terms of how it's disseminated organization-wide and where should it be housed, and we'll provide an update on this later. The team actually set a very aggressive reduction goal of 1.25 per 100 FTE, but the national benchmark is 2 per 100 FTE. The two other metrics I'm sharing today is the spill kit availability, which we're currently at 100%, and to ensure that we decrease false infant abduction alarm. There are no national benchmark with this. There's a lot of ongoing conversation with the vendor to ensure that we minimize alarm fatigue, because every time it goes off, there will have to be deployment things that will have to be done. So leadership during the meeting is reviewing the contract and will be engaging with our vendor to ensure that we actually have some process in deploying the latest technology to minimize and reduce alarm fatigue.
Is it usually just that it's something with the technology itself, or is it that, parents and things are taking babies outside of the area, setting off the alarms? Is it more human error, or is it more technological error on the?
So based off of the conversation we had at the meeting, it actually seems to be a combination of both. And here's why. Because it appears there are newer technology available in the market that actually adjust and really for those situations where it's obviously an error. But the system we have in place now will really pick any violation. So the goal is to really optimize and adjust our sensitivity in a way that it's not leading to unnecessary alarm. Okay. Next is rehab service, and it's a combination of physical, occupational, and speech therapies. And they usually help with developing rehabilitation plans for patients that have suffered stroke, post-surgery, or even in critical illness and other high-risk patients, with the ultimate goal of ensuring independence and really providing family and patients with empowering them to be able to take care of themselves and return to their baseline. So they did share some metrics with us. Being a comprehensive stroke center that we are in JPS, they looked at what is the time from stroke diagnosis to physical therapy being at the bedside of the patient. It's about 14 hours, which is really, really remarkable. And they also looked at percent of patient with stroke that is seen within 24 hours, they actually see 97%. And the reason it's not 100% is some stroke patients just have complete resolution of their symptoms. They present early, they got thrombolytics, and there is complete resolution of symptoms, and they've regained functionality, which we are seeing increasingly more frequently with improvement in our door-to-needle time, door-to-thrombolytics time. All of those metrics is actually showing up real time. It's actually showing up real time now in patient because they come in, they get the medication. It's like a clockwork. Everybody knows what should happen. And each and every step of our stroke program has a metric attached to it. So, and it's really showing a remarkable result. The other program that they shared, which I'm quite familiar with, was the ICU length of stay. And looking at stroke patients specifically, they've been able to reduce that to 3.2 days. But it actually goes beyond this because by embedding rehabilitation within our critical care area, we have definitely seen a reduction in ICU length of stay. Because with trauma, critical illness, post-surgery, cardiac surgery, neurosurgery that takes place in the ICU, there are 2 physical therapists in the ICU that's their full-time job. They ensure rehab. And they return back to they regain functional independence much quicker. We get them out of the ICU quicker, and a whole lot of them end up going home. So they have this program I'm very familiar with, and it really has been very remarkable what this team has done. Areas that we also discussed that we'll be going into with our rehab team, or at least build a process around, is the PROM, patient-reported outcome measures, like for orthopedic surgeries. We feel we need to incorporate them in the discussion as this is really becoming a main focus of CMS. And it's just a good policy for us to be able to compare what were your symptoms before your surgery and how do you feel after your surgery in terms of the impact of the surgery. So we will be working with them on that. And there are other metric development plans that's ongoing with the rehab team.
And that's more outpatient focused,
Yes,
right?
ma'am.
Okay.
That's more outpatient. Next is care management. As you all know, they really help with management of our complex patients. Amongst other things that this team does, the throughput management, the multi-visit patients program that I mentioned earlier, the SDOH screening and intervention, and care coordination to ensure seamless transition across all of the care settings. And even now, of course, they've been doing this for a while, but post-acute care at JPS to ensure that patient that needs to go to an LTAC goes to LTAC, patient that needs to go home goes home. Those that require equipment or even hospice transition, our care management team help assist with that. This slide is a background, and it really focuses on JPS connection patient, because for this group of patients, we are the provider as well as the payer, and it really lists the option of where patient could go to and the basic requirement for transitioning into that program after an acute care. So for long-term acute care facility LTAC, they still need some ongoing ICU level care. For rehab, they still need some inpatient rehab. They still need some therapy before they regain full independence outside of the hospital setting. And of course, the skilled nursing facility, they still need some low-intensity medical care that's ongoing. Home health and outpatient care. So this team, the post-acute care management team, helps coordinate all of these. And they have a very good and robust program, and did share some of the activities with us. They've been able to expand our post-acute care network from 3 skilled nursing facilities now to 11, from 1 inpatient rehab facilities to 3, and from 2 home health providers now to 8, and of course they've expanded our hospice providers to 10. They have developed this really comprehensive and well-thought-through map that actually they give to patient in terms of location of all of these facilities so they can select and family can go vet those places and make selection. And also for providers as well as nurses to be able to kind of like at least discuss with the patient in terms of where these services and this post-acute care network are located. Beyond that, they also follow up with each and every one of these facilities on a quarterly basis to kind of like review the quality of care that our patient that we are transferring to them, what they are getting, any issues, any citation from CMS of these facilities, what mitigating plans do they have in place, and any impact on our patient. So they do a lot of work and with this program, and the impact is very clear. As you can see in some of the metrics they shared with us, emergency department admits from SNF, and these are groups of patients that are transitioned to skilled nursing facilities. The numbers of patients in FY24, 16 compared to the year before, which was 29, so significant improvement. And this is also reflected in all of the other metrics that were shared in terms of inpatient hospitalization, observation hospitalization, and average length of stay at these contracted facilities. And of course, they are also able to connect this patient with follow-up care as outpatient post-discharge from the SNF facilities. So you could at about 81%, which is really, really good.
I think one of the challenges with SNFs in general, and I feel like this is addressing it a little bit, is just they're just such black boxes. Patients tend to go there, you just don't know what happens, and they get discharged to your care, and you're like, and so I don't know how much the care management team has access to it, but especially at those 14-day post-SNF discharge follow-up appointments, if they could be proactive about getting the providers the notes from the SNFs, it's really helpful, because it's always like the patients have all new medicines and are clueless as to what happened in the SNF. Yeah.
This is dear to my heart.
Okay.
Post-acute.
I'm glad to hear this.
Yeah, no, because I was really worked with Devin Armstrong, who leads our care management team, to develop the post-acute program. And so our care managers are actually embedded and rounding in these skilled nursing facilities. And so they're the ones who are managing that transfer back to their primary care physician in the network here at JPS. And so that's the reason for this success, because they're in there in the skilled nursing facility making sure they're getting the therapies they're supposed to get, making sure they're getting them with the frequency that was ordered, as well as just ensuring, the transitions of care, because that starts day one when they entered the skilled nursing facility, to get them transitioned back to home health even. Before, we would see patients that would linger and languish at a skilled nursing facility for weeks and not transition back to home as quickly with home health services, and really to get them back to their baseline before they were admitted. And so remarkable work. I think the other part of this really is the collaboration with those skilled nursing facilities. We've taken people off, we've added people, but those quality meetings that we have with their leadership to go through the patients that are in their facility, and then to look back and look at those data points related to the care that they received. And so did they go to the emergency department? If they did go to the emergency department, did you call us first? Did you call their primary care provider first? And so rapid real-time intervention is key to the data points here. So a lot of hard work for sure. Initially, like he mentioned, we only had a few skilled nursing facilities. Now we have 11, so we're covering the entire Tarrant County. So if I live, over here in North Richland Hills, for example, I don't have to go to a facility where my family can't get to me close here to the campus. And so a lot of great work over the last few years actually with this program.
Yeah, I had a couple of questions. The facilities on slide 32, those are all contracted? Those aren't JPS facilities?
They're not JPS facilities, no. We contract for the services.
And then on slide 33, the metrics, is that coming from the entire JPS patient population, or just Medicaid or Medicare?
These are the patients that we manage, the JPS connection patients.
These are only connections that are on here,
Yes.
okay?
Yes, exactly. Because those are the ones that we are able to manage because we, again, to his slide earlier, we take care of them, right? We're the provider as well as the payer. So we're able to essentially do what an insurance company does with care management services outside of the hospital as well. Our star Care management? All right. Okay, I think we're staying on track, so.
And of course, Infection Prevention and Control Committee, we've always brought the work of this committee to the board quite frequently, virtually every meeting. They are a multidisciplinary committee led by infection prevention expert, both an infection prevention specialist as well as an infection prevention medical director who is infectious disease boarded. And it also consists of nursing, pharmacy, allied staff, environment of care, and EVS services. Everybody is involved in this committee. And they focus on hospital-acquired infection tracking, education, as well as outbreaks management. And of course, they also include outbreak stewardship and ensure compliance with NHSN, which is a CDC arm that monitors this, and other quality metrics attached to infection control. The main metric that they share, in addition to others which I'm going to be sharing, is hand hygiene. Again, this is really one of the most important methodology of infection control in terms of preventing HAI in the hospital. And we continue to maintain a very high level of focus on hand hygiene, leadership rounding, staff education. One of the other ideas that we're exploring is actually to further gain additional insights into our hand hygiene compliance is to use proxy measures such as supply chain data. How many hand sanitizer are we consuming? Has there been any change? How does that look like per unit? Again, it won't give us all of the information we need, but it will give us a very good sense of what's going on and potentially be our canary in the coal mine if something is going on in a particular unit. So we're really working on that and exploring it, and we'll share that data with you shortly, once we have it. They also look at catheter-associated UTI CARDI. We are continue to monitor. Our goal is 0 for this, and hopefully, we hope we continue on the trend that we had last year, that we had almost 90 days of no CARDI. We are going for the same. And the next is central line-associated bloodstream infection. We are watching those closely as well and helping all of the teams be compliant with all of the insertion bundle and other monitoring bundles. Surgical site infection is a main focus. We had some challenges earlier, last year, but I think with all of the effort with our surgical colleagues, we have turned around, we have turned a corner, and we've been able to mitigate those. We still perform individual patient level review with every single cases of any hospital-acquired infection, including colon SSI. And this C-section SSI, we continue to do very well on those as well.
Well, as we do fewer C-sections, this will get better anyways. Thank you, Dr. Badamosi. I appreciate you going through all of that information very quickly. Anybody have any questions?
No, I just want to say, good report.
Yeah.
Really informative. Thank you.
All right, well, I do think we have some stuff in close. Okay, so I am going to go ahead and close the open session and open the closed session.
Okay.
A lot of stuff.
So we will go ahead and adjourn. Thank you all for being here today. I appreciate it.
Thank you, Dr.
You're welcome.